Hello, and welcome to Brook Lane's Facebook Live event. Recovery is a Journey. I'm Kurt Miller, Community Relations and Education Manager for Brook Lane. For information on future programs and events, please visit brooklane.org. You'll also find recordings there of our Facebook Live programs, and our YouTube channel has videos on it on a variety of mental health topics. This is a good community resource for everyone. If you have any questions during the program today, please type them into the comments area and I will relay them to our speaker. Thanks for joining us. September is National Recovery Month, so it's appropriate that our topic focuses on recovery being a journey. Living in recovery is a journey that's not always straight and steady. It has its ups, downs, and curves. There are many setbacks, but there also can be new discoveries as well along the way. The journey sometimes is difficult, sometimes is rewarding. It requires daily engagement and action to be successful. Donna Fogle is with us to share more about this journey. Donna is a licensed clinical social worker at Brook Lane's North Village outpatient office and in our InSTEP, or Integrated Substance Use Treatment Program. She works with adults from many different backgrounds. Donna has more than 37 years of experience working with individuals with behavioral health issues. I've had the pleasure of working with Donna numerous times and occasions to present information to our community. Welcome, Donna, and thanks for being with us today.
Hi, I'm Donna Fogle, and I'm with Brook Lane at the North Village location. I'm really excited to be here today talking about recovery, especially too often we focus on the substance use disorders and the relapsing potential that happens with most of our folks. And we don't give near enough attention to the recovery process, and people do recover. So I'd like to really highlight that today. I thought one of the ways we could do that is by my sharing 4 case studies with you based on real clients that we've had in our program. These clients, the profiles have been changed slightly, so they're not exactly the clients that we have here, but they are based on our real clients. Typically here at Brook Lane, we have a multitude of treatment opportunities. We have outpatient, we have individual, we have intensive outpatient. Most of our clients, and I'm saying 80% and more, are from 40 to 80 years old. Our oldest participant is 80. All of them have worked or are working. Most of them have family. Very few of them are what you see in the news, on TV and in the newspapers about what folks look like who are substance abusing clients. So I really want to highlight that fact. These folks are around you every day. And so let's start talking about what that might look like. The screen is visible, right? So let's talk about recovery as a journey. What you see before you is the stages of change. Whenever an adult, or a child for that matter, decides that they're going to make a change in their life, we go through a process, and we don't really even decide to do that. Normally, we start out in a place where nothing's wrong. I don't need to make any changes. So we just let things go as it happens. But then as we're living daily life, sometimes we come upon an issue where maybe I need to make a change. Maybe it has to do with a job. Maybe it has to do with a partner. Maybe it has to do with the place where you're living. But we start thinking like, maybe I need to make a change. And that's when we start contemplating, what is a change? What do I want to get out of that change? And how do I do that? Once we kind of fine tune that decision-making process, then we go into preparation where we're actually gaining the tools to get there, and action where we actually put those into action. And then once we get where we want to go, we have to keep doing something so that we maintain that. When a person starts using some kind of substance, they don't just wake up in the morning and think, I'm going out and I'm going to start doing something that's going to ruin my life. They usually go through this very same stage of change where they think about something. Maybe they're exposed to it in high school, maybe in the workplace, maybe a neighbor, whatever. Somebody says, let's come on and let's smoke a little weed, or can you come over and have a drink? You don't normally think that when you do that, it's going to become a problem, but you go through these stages of change. And recovery, we go through the very same changes. We start thinking, maybe somebody decides that maybe their substance use has become a little problematic and they need to make some changes. Usually they start thinking about, well, maybe if I just don't do it now, or if I don't do it with this person, or if I do it only on the weekends. But then they get down to the place where maybe I need to make a change, and they start contemplating it. Then they make preparation, then they go into action and maintaining that as well. So keep these stages of change in mind as we go through talking about these case studies. The first person I'd like to talk to you about is a 73-year-old male. He presented to us at Brook Lane because his wife thought that his alcohol use was problematic. And it was. He was 73 years old. He had very little support here in the community except for his wife. He was drinking way too much. He was falling a lot. He was driving when he shouldn't. And there were a lot of issues that went along with that. His one son that's still living was living in Germany. And as you look at these case studies, you'll notice that I've highlighted some things in red. These are things that contributed to the substance use becoming an issue. So he had one son that was living in Germany, so he was not here in the States. Son 2 committed suicide 10 years ago, a very traumatic event. He was medically retired as a police officer due to medical and emotional trauma on the job. 6 years ago, his left leg was amputated due to infection following a knee replacement. He had the prosthetic, but when drinking, he frequently falls. There was one story where he actually had tried, a neighbor had knocked on the door and he was trying to get his prosthetic on and fell again right into the neighbor's lap when he opened the door. So the alcohol use and the prosthetic were causing increased problems. As a result of the pain issues with his amputated leg, he had been prescribed pain medication. This man never used unprescribed medications except for his use of alcohol. The prescribed pain medications combined with the use of alcohol was a problem. Even if he didn't drink, the pain medications were an issue with him. So at that point, his wife strongly encouraged him to go into inpatient program. And he did stop using opiates for pain, and dramatically in group, he over and over talked about the fact that the pain was no different with or without the pain medication. He was in pain with the pain medication, and he was in pain without the medication, so he really didn't need it. However, when he stopped taking the pain medication, he did start drinking more often and more problematically. He had not used opiates for over a year when he entered our program, but the alcohol use had increased. He did have a family history of alcohol use. His wife, even when he entered program, had already started to attend Al-Anon. So you can see this client had several traumatic events going on in his life. One, he was 73 years old. He was losing some of his independence. His son, who he had lived close to, had committed suicide. He was medically retired as a police officer, so he lost his status in the community. He lost that productivity he got as an active police officer. Then he lost more independence with the loss of a leg and getting used to a prosthetic, and he was prescribed the pain medication. In addition, there were genetics there involved, so there was a chance that he was going to become problematically involved with alcohol anyway. Al's journey looked a little different than some people. He presented to Brook Lane. He came into our InSTEP program. He attended IOP, intensive outpatient, which is 3 times a week, 3 hours a day for at least 6 weeks. That way you get a steady foundation for your recovery. He then transferred over to our outpatient treatment, which is 1 hour, at least once a week, but it can be up to 5 times a week. And he was in our program for 2 years. He was also taking oral naltrexone, which is a medicated assisted treatment that helps folks not crave alcohol quite as much. It does not make you sick. It's not a miracle drug. It just helps you not crave alcohol quite as much. Initially, he had frequent relapses during his treatment. Most of those would end up in the ER because of a fall or because of something that was going on in his brain where he was making irrational decisions. On the last time he visited the ER, he was diagnosed with a form of alcohol-induced dementia called Korsakoff syndrome. This caused by a vitamin deficiency, but it causes a form of dementia that can get worse if you continue to drink, but can also get better if you stop drinking. This was the time when this client decided that he was going to stop using alcohol no matter what. So at that point, he entered lasting recovery. Now, interestingly enough, each time he relapsed, he would still come to group. Several times he came to group under the influence of alcohol. He was also driving his car. So we did have several issues with this gentleman because his problem solving was significantly impaired. But with that last ER visit, he did enter recovery. It was sustained recovery. He ended up moving out of state to where his daughter was living in late winter last year. Last time I talked to him, he was in the spring. He was loving life. He was with his grandchildren. He was using supports within the community where he was at. His wife is still continuing to attend Al-Anon. He had started to attend AA so he could form a social group. And as a result, his recovery journey was successful, but it was based on a foundation of coming into contact with treatment professionals and a social group that he found in the groups that he was attending here. The next person I want to present to you is a 66-year-old female. You will notice these are both older individuals, very successful in their own way. This client is still employed as a registered nurse. No, wrong person. This is a 66-year-old female, and she presented for therapy due to bipolar disorder and anxiety. This was several years ago. She was one of the first people that was ever prescribed opiate pain medications by pain management due to her fibromyalgia. She presented for treatment with the bipolar disorder, but she has no idea about her genetic makeup because she was adopted at birth to a military couple while they were in Germany. He was in active duty until retirement. They moved back to the States. Her father was still on active duty, so he was away frequently. And she was in the care of her mother, who was both emotionally and physically abusive. So we have an adopted child in an unstable family. So we have contributing factors. She does suffer from significant pain issues with fibromyalgia, and she has a mild traumatic brain injury, probably from birth, but the records are a little unclear. She was involved in 2 emotionally and physically abusive marriages. She does admit that her bipolar disorder was probably significantly impacting those marriages, as well as her choices in partners. She did have 2 children. Interestingly, both of those children have bipolar disorder in addition. She does have no information about her biological parents, so we have no information in that respect. Throughout our time together, which has been significant, probably close to 10 years, we have always concentrated on managing her bipolar disorder and the anxiety disorder that goes with that. She always took medication as prescribed, including her pain medication. At times, due to other issues, doctors would try to change her medication or increase dosages. For those of you who don't know, with opiate pain medications, you do increase a tolerance. And as that tolerance grows, you no longer get the relief that you need from the pain. So doctors continue to add dosages onto that, change medications, combine medications. Each and every time somebody tried to make one of those changes with her, she would have significant medical issues. Like sometimes she would stop breathing and they would have to put her in the hospital. Sometimes she would become overly impaired. So once she got to the upper levels of her dosages, she could not manipulate those dosages anymore. At this point, she's 66 years old. Somewhere around end of November, December last year, she started coming. Well, she was getting in-home care because she has several medical issues, and her caretakers would come to the house, her family members would come to the house, and she was not in touch with reality. She wouldn't know where she was. She would lose balance. She would be doing things that were very out of character for her. Each time they took her to the ER reviewed her medical history. They couldn't find anything significant. They did urinalysis and lab testing. Of course, she was positive for these medications, but they couldn't measure the dosages. On treatment by her primary care, her pain management doctors, and the doctors in the ER, along with work with her psychiatrist, it was discovered that what was happening was due to organ change because of age and continuous use of opiates over the period of time, she no longer had a tolerance for these medications. Even though she was taking the prescribed dosage, that prescribed dosage became a problem. For this client in particular, it wasn't that she was intentionally having problematic drug use. It was that those medications no longer were doing what they were supposed to be doing for her. And in fact, they were impairing her further. With this client, her recovery journey was fairly simple. She continued therapy. She had medication management for her psychiatric issues, which she's always done. But under supervision, strict supervision by her pain management and primary care physician, she titrated from all opiate use under the supervision of these physicians. At this present time, and probably for the last 3 months, she has been taking no opiate pain medications. She continues therapy as well as working with her doctors, and she has no more incidences of the blackouts or those temporary states that look like dementia. Please highlight this. This was not a person who was intentionally abusing drugs. She was following a doctor's advice strictly, and this is where it still caused problems for her. The third client I want to talk about is a 43-year-old female who identifies as gay. She has not been in a relationship for over 10 years, lives with her parents, and has little independence, primarily due to the fact that she has a history of substance abuse and her parents do not trust her. She's on disability due to back issues and psychiatric diagnosis, so she doesn't get out to work. She has little socialization, and her only friends are her old friends that she used to use substances with. She does have family close to her, but her life is very closed and very small. She presented for therapy due to her psychiatric issues. Her medication management is provided through Brook Lane for co-occurring depression, anxiety, post-traumatic stress, and opiate use disorders. But she also uses a methadone clinic in town, and she uses her methadone as prescribed by the methadone clinic. At 10, she was sexually abused repeatedly by a sitter. So we have another traumatic, and we have another contributing factor. Up until her late 20s and early 30s, she did use multiple substances: marijuana, alcohol, different opiates, some sedatives, tried some stimulants, but opiates have always been her drug of choice. She never shot medication using an intravenous method. She always used pills, On occasion, she would use those intranasally. That became her drug of choice in the late 20s and into her early 30s. About 5 years ago, she went into methadone maintenance. It's important to also note that she has no noted family history of substance use disorders. She entered a methadone maintenance 5 years ago and has been totally compliant with that clinic as far as anyone knows since that time. She's not used any other substance. She attends therapy weekly, and she uses psychiatric medication as managed by our psychiatrist. This client, due to a recent medical and up until this time, we've not even talked about the fact that she could titrate off of methadone or switch to Suboxone or another medication-assisted treatment. Because she's done well on methadone maintenance, she has no desire to use unprescribed medications, unprescribed opiates. And so this method of recovery was working for her until about a month, 2 months ago, when she started developing some medical problems as a result of continuous use of opiates, even though it was a prescribed one, because methadone is an opiate. It's a long-acting opiate, which is why it works with folks to help them titrate off of unprescribed opiates. So she has been taking methadone. It was causing medical problems. She was in the hospital for 3 weeks, had 4 surgeries, and at this point is home, is doing well, is back in therapy, very calm. But the last time she came into therapy, she did herself state to me that when she gets totally healed from her medical problems, she's willing to work towards recovery by coming off of methadone working with her prescribers. So this is a very different recovery journey than the 2 previous ones. 1, because of her drug of choice. 2, because of the medical complications that's caused by her medical choice and the treatment for her drug of choice. But her journey did include medication management for her psychiatric issues and weekly therapy. And the last client is another 66-year-old female. This person is an RN, a registered nurse, and she is still working. This person has only used alcohol for the last 10 years. Prior to that, she had no need and she had no desire to use alcohol because growing up, she lived with a father who had a severe case of alcohol use disorder through most of her childhood, who was abusive both mentally and physically. She presented for treatment here 4 years ago because she identified her drinking as a problem. It was not interfering with work. She had no legal problems. At this point, it had not caused problems with her marriage, but she noticed that she had started using alcohol to deal with stresses of her unhappy marriage. The alcohol use was increasing, especially on the days when her husband would go off golfing or go out with his friends. And so she was uncomfortable because she saw herself becoming her father. She presented for treatment here about 4 years ago because she identified drinking as a problem. Up until that time, she would maintain sobriety for 2 to 3 months at a time, and then she would relapse. Each time she would get close to that 2 or 3 month place, she would go through the very same cycle where she'd get unhappy with her husband. He would leave the house because he was retired. She would have the opportunity. She'd find herself at a liquor store, and the cycle kept going over and over again. At this point, interestingly enough, her father is 92 years old, living in assisted living on the other side of the country, and he still drinks a 1/5 of some kind of liquor daily. And this is documented by her brother as well as the professionals at the assisted living facility. She has been diagnosed with a sleep disorder and generalized anxiety. Her recovery journey adds something different that the other 3 did not. Initially, when she saw alcohol use as a problem, she started attending Alcoholics Anonymous. This was over 5 years ago. At the same time, She had a breathalyzer installed on her car. For those of you who do not know, this is a process that usually happens with the courts, where they order someone who comes into courts for a DWI to have this installed on their car, where you have to blow into the breathalyzer and the car will not start unless you're under a certain blood alcohol level. She had this done to her car with the cooperation of her husband because she saw a need to have an extra level of comfort and safety between her and getting to that alcohol. But she was attending Alcoholics Anonymous 3 to 4 times a week, was working with a sponsor. 4 years ago, she presented for treatment here and has attended outpatient groups weekly since then. She continues to attend outpatient groups and AA because she thinks the socialization with the folks who are other folks who are in recovery, as well as seeing new folks coming in who are still struggling and hearing her story over and over again, has really helped her maintain her sobriety. 3 years ago in May, she celebrated 3 years. She started her sobriety, her absolute sobriety. In May of this year, she celebrated 3 years of active recovery using AA, group attendance, therapy here with us, medication management with one of our psychiatrists. And she also uses volunteer work at a nearby stable where she works with horses as part of her recovery journey. A little different than most of the folks that we've talked about. So if you look at what we've talked about with these 4 clients, you see the cycle. At first, it doesn't seem like it's a problem. Then they start contemplating that something's not going right in their life and they need to make some changes. At that point, then they start the recovery journey, whatever that journey looks like, and they do the preparation and the action. And at this point, some of them are in a maintenance place. On this slide, you will see something that professionals have put out, and I have no data to support this, but in my experience, I believe this illustration is a little flawed. Not every not every person with a mental health disorder has a substance use problem, but I have come into contact with very few people with substance use issues who do not have a co-occurring mental health issue. Either it was there before, and the substance use was used to try to treat that, or it came about as a result of their substance use. But very often we find folks with co-occurring disorders. I would also add a third co-occurring disorders with this, because you also heard in a couple of situations where not only did we have co-occurring mental health and substance use issues, but we also had co-occurring physical disorders. So it's very important to be aware of this correlation. I'd like to talk a little bit, but I'm not going to give much attention to this, that everybody who uses substances is not addicted to that substance. In fact, I don't even like the word addiction. I prefer physical dependence, because your brain is a part of is an organ in your body. And when your brain malfunctions, then that causes some of these problems. Most of the folks in the United States and around the world can use alcohol responsibly on a case-by-case basis, and it does not become a problem. Some folks now are using cannabis on a case-by-case basis, but they do use it sporadically, and it is not a problem. Not everybody that uses a substance, not everybody that's prescribed an opiate or some other medication is going to become dependent on it, but it is possible. But use itself is not an indicator of a problem. Some people do abuse substances during periods of their life, when there's a grief issue, when there's maybe a marital problem, some kind of stressor going on. Some people abuse a substance for a period of time, and then they stop, and it doesn't become an issue. Some people, however, become physically dependent on substances, and this is very different. You have severe emotional and physical consequences when you try to stop. And then, of course, some folks characterize addiction, and that's when dysfunctional behaviors usually come in, stealing, lying, and those kind of things. There are some behavioral indicators of abuse. It's the kind of the normal things that you hear about. Work performance, complaints from coworkers, partners, unusual needs for money, not having money, those kind of things, and frequently getting into trouble. Problems with relationships are usually indicative. So let's talk about recovery, because this is the important part. It has to be a multifaceted approach. The individual has to be motivated. The family is usually going to become involved. Peers are very important, as you saw with our group attendance and people attending AA. Folks in your neighborhood, the environment that you're in. If you're as a child, sometimes school becomes important. The community, AA, NA, some of the other resources in the community are very important, as is treatment. There are several kinds of treatment options. We have and not just Brook Lane, but other places in the community, we have traditional outpatient therapy. It's group and individual as needed. Groups are 1 hour at a time, at 1 or more times a week. Intensive outpatient, as I've talked about before, is 3 days a week, 3 hours per session. Sometimes it takes inpatient hospitalization. As with a couple of the clients that I've talked about previously, they have participated in inpatient hospitalization when their use became an issue that it could not be treated initially within the community. They needed to be removed from the community, medicated, treated by treatment professionals, and then they experienced a continuum of care where they were stepped down to other continuing care options. Medication-assisted treatment is also an opportunity, and we'll talk about that in a minute. Brook Lane does offer treatment for substance use disorders using a continuum of care. We offer everything from individual through outpatient up into intensive outpatient, along with treatment for co-occurring disorders and treatment by our psychiatrists or our nurse practitioners. I would like also to highlight the fact that Washington County Health Department, Meredith's Urgent Care, a lot of other places in the community are using what's called peer support programs. These programs use folks who have mental health and histories of substance use disorders who go out into the community and work with their peers, and you do the on the street kind of socialization, leading folks in directions that they've found by their experience to be successful. The Washington County Health Department does have peer support specialists. You can contact one by calling the behavioral health unit. So let's talk a minute about pharmacological interventions. Traditionally, up until a few years ago, the one and only thing that you might hear about would be antabuse. Antabuse is a drug that you take, and when the person takes it, if they have any exposure to alcohol whatsoever, they become incredibly sick. Nausea, flushing, any of those kind of things. Any food that might have alcohol in it, mouthwash, any of those kind of things would cause a person to become incredibly ill. Antabuse is not used very often anymore, partially because if people have compromised livers due to their substance use, antabuse can exacerbate that. As I talked earlier, there's also the possibility of methadone for opiate use disorder, and I see a spelling error there. Methadone is an opiate. It is a long-acting opiate. Usually you start out by going to a methadone clinic once a day, and they administer you 1 dose, because sometimes folks who are using substances cannot be trusted with more than their prescribed amount on any given day. As they participate in the clinic, they earn the ability to take home maybe a couple of days, maybe a week, in some cases, maybe a month. My client that is on methadone maintenance now could be at a place where she would get a month's worth of methadone to take home with her. She doesn't, after all this time, she still doesn't trust herself with that. And so she goes every 2 weeks, gets 2 weeks worth of opiates, takes it home, puts it in a lock safe that her parents are in control of, so that she still only gets 1 dose a day. but it's supervised and it's locked up. One of our newest medications that's on the market is Suboxone. It's a partial agonist, which means it has some opiate in it, so the person does not go into withdrawal, but it also has something in it that is an antagonist, and it makes you it keeps you from getting too high on that medication. It just keeps you safe so that you can titrate that dosage down and titrate off of medications. Or in some cases, people stay on Suboxone for a long time. If it works and the person is no longer using unprescribed medication, this is a success, and it's in the hands of the person who's taking it. We also use, and we use this a great deal here at Brook Lane, naltrexone, which comes in two forms. There's an oral version called Rivia, and there's an injectable version, which is Vivitrol. Vivitrol itself works for 1 month. You get one injection in your rear end once a month. It stays there. Rivia is a daily oral. You take it, and it blocks the effect of alcohol and opiates, so that if you use them, you don't get the same effect off of it. In fact, it blocks the pleasure receptor. So if you're using alcohol or opiates to excite your pleasure receptor, it blocks it off so you don't get those effects. Some people also say that it really helps with blocking cravings, so they don't want alcohol as much. The other thing that we use, but not traditionally as an intervention, but in the case of overdose, is of course naloxone, and that's Narcan that is administered when somebody goes into opiate withdrawal. Just as an aside, the only two drugs that you can die from withdrawal of that drug is alcohol and benzodiazepines, such as Xanax or Valium. So these are some of the support areas that are there for folks who need and want to go into recovery. There is Al-Anon for families of folks with alcohol and other drug problems. Alcoholics Anonymous is a 12-step group with some spiritual components. It's available within the community. Narcotics Anonymous is there for folks who are dependent on other medications and other substances. There's also Codependence Anonymous. It's another 12-step group, and it tends to draw folks who seem to keep getting into relationships with people who they need to fix. But it's very 12-step based. Another addition is Smart Recovery. This has no spiritual connection whatsoever. It's based on cognitive behavioral therapy and a 4-point program: building and maintaining motivation, coping with urges, managing thoughts, feelings, and behaviors, and living a balanced life. They have an excellent website. So if you ever need any additional information, please do visit Smart Recovery. Lots of great information there. Celebrate Recovery is another spiritually based program. It not only works with the folks that have substance use disorders, but other things that are bothering their life. People with mental health problems, behavioral addictions such as gambling, sexual preoccupation, those kind of things are welcome in Celebrate Recovery. And it doesn't just invite the folks that have the problem. It also brings in the families with them. A lot of times in these groups, and I've noticed lately in some of the publications, they have it's a couple-hour meeting. The entire family goes, including kids. They have a meeting in the beginning, everybody together, and then they separate into different groups. The folks who have the problems go into one area. The adult family members go into other areas. And the other thing that really impresses me is that they're even having kids groups within these, so they can address the issues with a smaller part of our population that are affected by substance use. I do think the Zion Church of Christ location is not in operation. There is a new location in the West End at this point. The other treatment opportunities within the community, I think there are others, but these are the primaries. ADAC is on Virginia Avenue. Of course, Brook Lane is here. Serenity is on Northern Avenue in the Washington County Health Department. While they do not provide treatment anymore, they do have resources, peer support, and harm reduction services. And I just mentioned harm reduction. When I first started doing substance use treatment, it was you stop or there's no treatment available for you. What we know best is that what we need to do is bring people in and give them healthy relationships so that when they're ready to change, we can make that change, and harm reduction is one of those options. I'll skip. I just want to make it very clear that the addiction is not the person. You can love the addict and hate the addiction. You love the person, but you hate their behaviors. So it's not understanding the person you're involved with who may have a substance use disorder is not the disorder. They are a human being. They have feelings, they have emotions, and the person that you know and you love is in there somewhere. We just need to treat that substance use disorder. And I would love to give you some opportunity if anybody has any questions, comments, things that you'd like to have clarified, please feel free to message over Facebook, and Kurt will tell me what they are, if there are any.
We have none so far, Donna, but I will keep you posted here as we continue to watch this for a moment.
If you need additional time, if something comes to you later, please do not hesitate to contact Brook Lane. We do have our continuum of care. If you think you need services, understand that the person is not going to come into treatment until they're ready to come in, but you as family members also need support. So do not hesitate to call and get involved with Brook Lane. Call, get an appointment for an evaluation. You'll come in, meet therapists, get referred to somebody for individual care, and that person can help you until that person that you're supporting wants help also. And if we have no questions, I don't think I have any more to offer at this point.
No questions at this point, Donna. I want to thank you so much for being with us and for sharing today so that people can hopefully understand a little bit more about recovery being a journey. And I think you did a great job with that. Thank you.
Thank you for your help.
Take care.